Good afternoon, everyone, and welcome to today's RDLS session on National Guidelines for HIV Care and Treatment 2021. And the topic is HIV and OI, gastrointestinal system. And today's speaker is Dr. J. Archana ma'am, and she is working as an assistant professor with the Department of Medicine at Gandhi Medical College and Hospital, Hyderabad. I request ma'am to kindly take over this session. Thank you.
Good afternoon, everyone. Today we are going to learn opportunistic infections regarding GI tract. So the contents of the session condenser. First, we know the backgrounds, and we are going to discuss regarding oral lesions like oral candidiasis, esophageal candidiasis, angular stomatitis, Kaposi sarcoma, and necrotizing gingivitis. And we are also going to learn different types of diarrheas, causes, and their treatments, and other bacterial infections. And we are going to learn about the management of diarrhea in child living with HIV, and a note on cryptosporidiasis, cystoisosporiasis, and other causes of diarrhea in CLHIV. And there is a note on anal lesions, different types of anal lesions. So coming to the background, as we know, most of the times HIV patient, when they are not known their status, most of the times a patient presenting to you with chronic diarrhea, we screen for HIV, and we came to know that he is HIV positive. So in chronic diarrhea evaluation, screening of HIV is also one of the important points. So that was common with this. So GI disorders are most common complaints in HIV patients, and the evaluation of GI is very difficult as there are so many non-specific symptoms, so evaluation becomes very difficult in GI. And at the same time, you may have a same multiple infections at the same time in a single person. So evaluation becomes very difficult in GI disorders. So common GI manifestations in HIV disease, as we know, nausea, vomiting, diarrhea. There will be dysphagia, rodinophagia, diarrhea, GI bleeding, jaundice, abdominal pain are common. Some people have hepatosplenomegaly, some present with anorexia disease. So coming to the upper GI tract, oral lesions, first we are going to learn. Among them, oral candidiasis is the most common presentation in HIV patients. As I said before, diarrhea, even the candidiasis also, a patient who is not known his HIV status comes to you with oral candidiasis. First, we ask for the patient to go for HIV screening, because that was common it is in HIV patients. Apart from other, after ruling out other immunosuppressed state, we have to screen for HIV in case of oral candidiasis. If patient status is not known. So other oral pathologies presenting are angular stomatitis, necrotizing gingivitis, Kaposi sarcoma, and Oesophageal. So oral candidiasis, as we know, it is caused by Candida albicans infection, which is a fungus. It is more common even in immunosuppressed patients like infants, very elderly and debilitated patients, uncontrolled diabetic patients who is on cytotoxic drugs and who is on immunosuppressive agents, who is on prolonged steroid treatment or prolonged antibiotic treatment are also more prone to get oral candidiasis. So, if a patient with the HIV patient comes to you with oral candidiasis, it indicates that patient is having the more advanced immunodeficiency, and it comes under stage 3 disease. So usually the oral candidiasis will be present with the white color patches with the surrounding red color area, and these patches are usually by which you can differentiate it from here is a leukoplakia, this is the lips also. There are 4 types of candidiasis. Like it may present as a pseudomembrane, that is oral thrush, or it can present as a erythematous lesions. It can present as angular cheilitis or hyperplastic lesions. Usually they complain of not having a taste sensation, and they will say that they will have an odontophagia, that is painful swallowing uh, behind the throat, not behind the sternum. If they complain of pain behind the sternum, it indicates that candidiasis has spread to the esophagus and patient is suffering with esophageal candidiasis. Usually, we diagnose clinically by looking at the lesion, oral lesion, white color patches, and immunosuppression. Need a lab confirmation. We send the scrapings for microscopic examination where you can find yeast or hyphal funds. The stain we use are potassium hydroxide. Sometimes you may need a cultures for particular species of candidiasis. The treatment is we'll give a oral suspension of nystatin 1 ml 4 times a day for 5 days. Or you can give a 1% 4-trimethazole mouth pain. If patient is not responding, then you can give a systemic therapy, that is oral fluconazole 100 to 150 mg once daily for 1 week. So next, if a patient oral candidiasis has spread to the pharynx or oral cavity, then you can think that this candidiasis has spread to esophagus. And this esophageal candidiasis as oral candidiasis are difficulty in swallowing, especially pain behind the sternum. Okay.
Sorry to interrupt you, ma'am. I think there is some voice lagging. If you can please stop your video, that might help. Yeah. Thank you so much, ma'am. It could be
Oh.
because of low bandwidth. Thank you, ma'am.
Oh. So a patient with oral candidiasis complaining of pain during swallowing and pain behind the sternum, you can think of esophageal candidiasis. These patients may present with weight loss as patient is unable to take the food. And most commonly, it is associated with low CD4 count, and it indicates stage 4 disease. If patient has a danger signs like patient is comatose, that lethargic, is having a very weight loss, and other symptoms, think of alternative diagnosis rather than esophageal candidiasis. In children, usually they won't present classically as a dysphagia. They usually present with nausea and vomiting, and because of this nausea and vomiting, they won't take the food and fluids, and they present with dehydration and weight loss. Classical symptoms are absent in case of children. So, as we diagnose it depending upon the microscopic examination or regressions to the histopathological examination, where you can find higher forms of the esophageal candidiasis. The confirmation can be done by fungal cultures. So there are other causes of dysphagia apart from esophageal candidiasis. When patient is not responding to your therapy, you can think of GARD or HSV-related esophageal ulcer or ulceration related to the cytomegalovirus infection. Usually, cytomegalovirus infection ulcer occurs when in patients with CD4 count less than 50 and associated CMV retinitis. You can think of CMV ulcer. And other causes like Kaposi sarcoma and TB has to be looked for. So treatment is fluconazole 200 mg orally daily for 14 to 21 days. Check for the response after 7 days. If patient is responding, continue for 10 to 10 days to 2 weeks. If patient is not responding, think of alternate diagnosis like HCV or CNV. In case of HSV, you can give a acyclovir 400 mg 3 times a day. If you think it's a CNV related esophagitis, when patient is having CD4 count less than 50 and he's also having a CNV retinopathic features, you can think of CNV ulcer, and you can the treatment of choice for CNV ulcer is valagamsaclovir or gamsaclovir. If you think of TB, better you screen for TB and start ART. In case of children, fluconazole has to be given 600 per kg dose kg on day 1, then give 3 to 6 mg per kg first 21 days. So other oral manifestation we have seen is angular stomatitis. It presents as inflamed and painful knee cracks at the corners of the mouth, usually caused by the candidiasis. It can also be seen in iron deficiency, anemia, and other bacterial infections also. It will respond to the antifungal creams like 1% clotrimazole cream or anistat drops can be given over the cracks of the lesions. So other oral lesions we have seen is aphthous ulcers and herpes simplex virus related ulcers. Aphthous ulcers we know which are present over the mucus of the mouth and in the lips or sometimes on the tongue. Cause is unknown, mostly viral etiology. These are often persistent and painful lesions, especially HIV patients with low CD4 count. They are persistent. Treatment is effective ART can decrease the treatment. The herpes simplex virus ulcers are usually over the lips. They are extensive and recurrent lesions and extensive lesions and painful lesions. We can give paracetamol or tramadol to decrease the pain. And for HSV, you can give acyclovir 400 mg 3 times daily for 5 to 10 days. In case of children, the dose will be different, but the acyclovir can be given 15 mg per kg per dose 5 times daily for 7 to 10 days. If we start early, we can decrease the duration of the treatment. So one more oral manifestation is primary syphilis, also known as chancre. Primary syphilis, chancre or chancre look very similar, but the difference is this syphilistic ulcer is painless ulcer, whereas in chancre there is a severe pain. We can say chancre is caused by Haemophilus ducreyi. The chancre is by syphilis. Confirmation can be done by VDRL test, and treatment of option for syphilis is benzoyl penicillin 2.4 milliliters weekly for 3 weeks. So other manifestation common in HIV patients is Kaposi sarcoma. Usually they present with the purplish swelling over the mouth and gums. If it is present over the palate or oral cavity, you may think that it has involved pulmonary respiratory tract involvement or a GI tract involvement. You can confirm it by doing the X-ray and other respiratory symptoms. In case of GI involvement, people present with acute occult blood loss. So by doing the CBP, you can have a doubt that Kaposi sarcoma might have spread to the GI tract. So usually we'll diagnose depending on the history and the visualization of the lesion. You can diagnose the disease. So if patient is suffering with Kaposi sarcoma, you can think the patient is in stage 4 disease, and treatment is you have to start effective ART. Immediately start the ART treatment. And if patient is already on ART treatment but is having the Kaposi sarcoma, then send the sample for viral load, and better to switch to alternate treatment. Think of treatment failure and switch the second line treatment in HIV patients, and send the patient for chemotherapy. So one more oral lesion we can see in GI tract is necrotizing gingivitis. Gingivitis is nothing but inflammation of the gingiva, that is gum. It is very severe. Necrotizing gingivitis is very severe, that it causes severe pain and tooth loss and cold smelling breath. So treatment options, you have to maintain the oral hygiene, better to give antiseptic mouthwashes and treat it with metronidazole 400 mg 3 times daily for 7 days. And you can give a supportive management in the form of painkillers for decreasing the pain. Necrotizing gingivitis indicates that patient is in stage 3 condition, so better to start ART immediately. So apart from all these reasons, there are some other causes which may cause odinopesia that is painful swallowing. As we have seen, Candida, Oesophageal Candidiasis, HSP and CMV also. Some of idiopathic ulcers also cause painful dysphagia, GARD and drugs like azathioprine and NSAIDs. Other less common causes of odinopesia are TB infections, staphylococcal or encephalopathosis infection, some of the parasitic infections, and Epstein-Barr virus infection. So coming to the systemic after the upper GI tract, we can see the diarrhea, lower GI tract involving GI symptoms, diarrhea and other parasites. So before going to the diarrhea proper, we have to learn some definitions of the diarrhea. Diarrhea is defined as 3 or more stools per liquid stools per day, or more number of stools than the normal frequency in particular person. And sometimes this diarrhea may be associated with nausea, vomitings, and abdominal pain and fever. In children, you can define it as increase in the stool frequency to twice the normal of his normal frequency. Or if older children, you can define it as 3 or more loose watery stools. When diarrhea is associated with blood loss or blood stained stools, you can call it as dysentery. Acute onset diarrhea lasting for more than 14 days, you define it as a persistent diarrhea. When diarrhea is insidious onset and lasting for more than 14 days, it is called as chronic diarrhea. So this diarrhea, as we all know, that because of loss of fluid and electrolytes, it causes dehydration, and there is a malabsorption of all the nutrients, which leads to malnutrition. So malnutrition may again cause dehydration, and dehydration cause malnutrition. These are the vicious cycle run in the diarrhea in children. So diarrhea, you can divide the diarrheas into inflammatory diarrheas and non-inflammatory diarrheas. Inflammatory diarrhea occurs when pathogen invades the wall of the large bowel and it causes immune response and mucosal bleeding. Non-inflammatory diarrhea occurs when pathogen invades the epithelium of the small intestine, where we have a more of fluid and electrolyte losses, leading to the severe dehydration. The causes of acute diarrhea, acute inflammatory diarrhea, and acute non-inflammatory diarrhea, you can divide it. For in acute inflammatory diarrhea, you have a common bacterial infections like Shigella, Salmonella, Campylobacter, E. coli, and Clostridium difficile. Parasites like amoebiasis and viruses like CMV virus. Acute non-inflammatory diarrhea usually caused by the viral infections like rotavirus, enterovirus, and norovirus, and parasites like Giardia lamblia. So causes of chronic diarrhea, as we have discussed earlier, chronic diarrhea is most common. Most of the patients, HIV patients present with chronic diarrhea, where you screen and find out that patient is HIV positive. So one of the most common cause for chronic diarrhea is HIV. So among them, what are the causes of chronic diarrhea is, you can again divide it into non-inflammatory and inflammatory. Non-inflammatory is nothing but large volume water stools. We have already discussed. The common causes are coccidian parasites like Isospora, Leptosporidiasis, Microspora, and Cyclosporidia, Giardia lamblia, and Spondylitis tuberculosis. Persistent diarrhea in child usually caused by the malnutrition or E. coli infection. Sometimes you have to rule out cow milk protein allergy. Then antibiotic associated diarrhea and cryptosporidian infections. These are common in children causing persistent diarrhea. So as we know, diarrhea complications, it causes more fluid and water loss, leading to the dehydration and hypovolemia, which resulting in decreased blood flow to the kidney and acute kidney insult, and loss of electrolytes causing electrolyte imbalance, loss of malabsorption of other nutrients, and loss of nutrients causing malnutrition. Sometimes these bacteria invading systemically and causes sepsis. So bacterial enteric infections. Most of the times, GI tract is involved by the gram-negative bacteria. They're tenfold higher in the HIV patient as compared to the non-HIV patients or a general population. If your patient is on ART, you can decrease the rate of spread of this gram-negative bacterial infection. These bacterial diarrhea is greatest among the patients with CD4 count less than 200. And the most common organisms involved are Salmonella, Shigella, and Campylobacter. If patient is having a less than 50 CD4 count, you can think of Clostridium difficile infection. Most on the, as we know, as per others all, the diarrhea is commonly, or bacterial infection is commonly caused by contaminated intake of food and water. So these bacteria, their mode of presentation will be different. In some patients it is a self-limited gastroenteritis. Sometimes it may be severe and prolonged diarrhea and associated with fever, bloody diarrhea, and weight loss. And sometimes it may spread systemically, cause bacteremia and extra-intestinal involvement that is affecting the other organs. So how do you diagnose a case of bacterial enteric infections? First, take a proper history, complete and proper history from the patient, and you can diagnose the patient by sending the stools for cultures, blood and for cultures. Blood cultures can be sent if you suspect, if patient is complaining of fever, and if you think that a systemic spread has occurred, you can send it for blood cultures. In chronic diarrhea, evaluation is very difficult. You have to be very suspicious and very specific which test has to be sent and diagnose the case. Correct testing has to be done. So sometimes you may need endoscopy and taking the sample, intestinal sample for biopsy. Especially in cases of cryptosporidiosis, microsporidiosis, and CMV and MAC gastroenteritis, and some of the non-infectious causes of chronic diarrhea. To diagnose all these cases, biopsy is needed. Stool culture, if stool culture has not shown any enteric pathogen and patient is having proctitis or colitis, you should think of other STDs. So management, as we know, as patient with diarrhea, patient will have a dehydration. So first we have to correct the dehydration. That is, adequate rehydration has to be given. Antimotility agents better you avoid, and better you give a empirical antibiotic before giving the empirical antibiotic. Better you send a fecal sample for cultures. These stool cultures also, antibiotic susceptibility has to be performed, and then you can give a specific antibiotic. Empirical antibiotic when patient is having a more severe diarrhea, that is more than 6 stools per day, that is liquid stools or bloody stools, or patient is having a fever or chills, then better to give an empirical antibiotic. Mostly, and preferred empirical antibiotic is ciprofloxacin 500 to 750 mg orally for 2 times. If patient is having a persistent diarrhea, but there is no severe clinical signs, better you can wait until the evaluation before starting antibiotic therapy. After evaluation, you can start antibiotic therapy. I mean, you can withhold the antibiotic therapy till the evaluation is completed if there is no severe diarrheal signs. So So among the common causes, as we have learned, salmonellosis is very common. The treatment for salmonellosis, we usually prefer treatment is ciprofloxacin 500 to 750 mg orally 2 times daily. Alternatively, we can give levofloxacin, moxifloxacin, ceftriaxone or ceftriaxone IV or cefotaxime IV. Duration of therapy without bacteremia. CD4 count is more than 200. We can give up to 14 days. If CD4 count is less than 200, we can give up to 2 to 6 weeks of treatment. If patient is having a bacteremia, count is more than 200, you can give for 14 days. And if bacteremia persists or any extraintestinal manifestations are there, then you can continue the treatment. If CD4 count is less than 200, give treatment for 2 to 6 weeks. So among the next common cause is shigellosis, where patient presents with gastroenteritis and bacteremia. Gastroenteritis treatment 7 to 10 days is enough. If patient is having bacteremia, treatment has to be given for 14 days. If recurrent infections are there, treatment has to be extended up to 6 days. Preferred antibiotic ciprofloxacin. Alternative therapy levofloxacin, moxifloxacin, etc. Can give azithromycin 500 mg oral daily for 5 days. Next common cause is campylobacteriosis. Same, if simple gastroenteritis is there, you can give up to 7 to 10 days of treatment. If bacteremia is there, then give the treatment for more than 14 days. If recurrent infection occurs, 2 to 6 weeks treatment is enough. So preferred therapy here ciprofloxacin or azithromycin. Alternative therapy levofloxacin or moxifloxacin. In case of Clostridium difficile infection, go with vancomycin 125 mg 4 times per day for 10 to 14 days or metronidazole 500 mg 3 times per day 10 to 14 days. So here we have a separate topic regarding child living with HIV, the management of diarrhea in child living with HIV. So the objective of this topic is first we have to determine the diarrhea, whether he is suffering with acute diarrhea, dysentery or persistent diarrhea. Then look whether he has any dehydration signs or any other complication he is suffering with. You have to assess the malnutrition and also rule out other non-infectious causes of the diarrhea. And non-diarrheal illness like other systemic symptoms, anything is there that you have to rule out. And you have to check for a feeding before illness and during the illness. So history should be taken. History should be taken regarding onset of diarrhea, duration of diarrhea, number of spills per day. The importance is depending on onset of diarrhea, you can differentiate whether it's acute diarrhea or a persistent or a chronic diarrhea. Depending on the duration, the organism will vary and the treatment will vary. So proper history is more important. If whether the blood is there in the stool or not, and is there any vomitings? If so, how many episodes of vomiting? And you have to check for other systemic infection, systemic manifestations like fever, cough, and other any convulsions, recent measles vaccination or a measles infection, and the amount of fluid he is taken and food he is taken during the illness or preceding the illness. That might be the cause of his diarrhea. To evaluate that, you have to check for type and amount of the fluid he has taken before and during the illness. And there are some drugs which cause diarrhea, so you should inquire about the drugs, and sometimes they may go for local remedies. You should also inquire about this. And some people advise anti-natality drugs, whether he has taken or not, you should inquire, and proper immunization history has to be taken. After history, we'll go for examination where we have to check for dehydration signs. In those, first we will check for his conscious level, whether he is alert or he is restless, irritable, or he is lethargic or stuporous. Then you check for his eyes, whether they are normal or sunken. Whether patient is able to drink normally or he is drinking easily or he is unable to drink or unable to take the fluid. Check for the skin turgor. Colon pinching, whether it is normally going or it is slowly going back or it is taking more time, that is more than 2 seconds to return back. So diarrhea, as we have seen in the adults, even in child, we can divide the diarrhea into acute, persistent, chronic, and acute dysentery. Acute diarrhea is acute onset diarrhea lasting less than 14 days. Persistent diarrhea is acute onset diarrhea lasting more than 14 days. Chronic diarrhea is insidious onset lasting more than 14 days. Dysentery is when stools are mixed with blood. It is called acute dysentery. So when a patient with acute diarrhea comes, you have to evaluate whether patient comes under no dehydration category or a some dehydration category or a severe dehydration category. No dehydration means patient is alert, his eyes are normal, not sunken, his mucous membranes are moist, he is not thirsty, he is drinking normally and his skin pinch going normally. Where you plan, where you give a plan A, that is home-based regimen and with WHO ORS. Some dehydration means check for more than 2 signs. Among those signs, whether patient conscious level is restless or irritable, sunken eyes are there, or tears are absent, whether he is having a dry mouth, whether he is very thirsty and drinking eagerly, whether his skin pinch going slowly. Among these 5 points, any more than 2 signs indicates patient is suffering with some dehydration and go for a plan B, that is hospital-based treatment with ORS. If patient is having severe dehydration, that when patient is lethargic or unconscious, his eyes are very sunken and his eyes are dry, there are no tears, very dry mucous membrane, he is drinking very poorly and unable to drink the water, and his skin pinch is going very slowly, then it indicates patient is suffering with severe dehydration. Then go for a plan C where hospital-based treatment with IV fluids has to be given along with ORS. So what we have learned in the previous slide, that is given in this slide also. Classification of dehydration. We can divide the patient into no dehydration, some dehydration, and severe dehydration. When the fluid loss is less than 50 ml per kg, you can call him as a no dehydration. When fluid loss is less than 50 to 100 ml per kg, you divide it as some dehydration. And when the fluid loss is more than 100 ml per kg, you call them as a severe dehydration. So apart from looking for the dehydration, you also look for a malnutrition status, especially in case with the persistent diarrhea, where you also expect a malnutrition. So you should check for weight and height, whether very muscle wasting is there, any edema is there, or any signs of vitamin deficiencies are there. And you should also check for cough, any fever, fast breathing, chest in drawing, which suggests pneumonia. Our patient is having a hepatosplenomegaly, high-grade fever, you can think of a malaria. And look for oral thrush or any anal lesions, perianal satellite lesions to check for fungal infections. So usually in acute diarrhea, stool culture or stool microscopy is not needed. When patient is suffering with giardiasis and when we are not confirmed or not sure about the diagnosis, then only you can send for stool microscopy or stool cultures. Our stool pH also usually in acute diarrhea is not indicated. When patient is suffering with systemic symptoms like patient is having a cough, high-grade fever, and he's having altered sensorium, he's having a tachypnea, he's having oliguria, or is suffering with paralytic illness, then you can send the blood samples like CBP to check for the count, blood gas, ABG levels, and check for serum electrolytes, check for RFP, whether he's suffering with kidney failure, whether he's having dyselectrolytemia. To check all those things, you will send the blood sample. So not routinely, these are indicated. Only when there is a severe systemic symptoms, you send all the samples. So management of acute diarrhea, first you have to correct the dehydration. Dehydration has to be corrected, maintained, and adequate feeding has to be given. Early recognition of danger signs, as we have discussed earlier, fever, oliguria, paralytic ileus. Those signs early, you have to recognize early and treat accordingly. And also, you have to give oral supplementation Zinc. The usually recommended fluid is you ask home-based food for plan A, where you have to counsel the mother regarding how to prepare the ORS solution and how to give. And the home-based foods preferred is salt water, salted rice water, or salted yogurt, and vegetable soups or chicken soups you can give. Better you avoid commercial carbonated beverages or commercial fruit juices. And also counsel the mother regarding the danger signs, like diarrhea is persisting for more than 3 days, the fever is not decreasing, the frequency of it is increasing, blood in the stools, our patient is under conscious level is deteriorating, our patient is complaining of oliguria, then better you visit a healthcare facility. So children with some dehydration should be treated at hospital only with ORS. And the ORS has to be given during the transport also, so that you can prevent progressing to the severe dehydration. And all the children with severe dehydration has to be treated in healthcare facility with all facilities. So feeding, as we have discussed earlier, you have to evaluate what he has taken prior to the illness and during the illness. And 3 points has to be remembered, that feeding should not be restricted. And early feeding has to be done so that it will decrease the stool volume, will facilitate the more sodium and water absorption so that it decreases malnutrition. And it also helps in early recovery of gut epithelium and prevents the malnutrition. One child's status is improved, you can increase higher the amount of food than recommended. So zinc supplementation, usually in children with suffering with acute diarrhea, we give zinc 20 mg of elemental iron per day has to be given for 14 days. It is helpful in decreasing the severity and duration of the diarrhea, so that it can prevent child progressing into the persistent diarrhea. If patient is having the vomitings, give ondansetron to decrease the vomitings. Single dose of ondansetron, 0.1 to 0.2 mg per kg per day is needed. So the points to be remembered in child living with HIV, suffering with diarrhea is antibiotic usually not indicated in acute diarrhea. Antibiotic has to be given only when you suspect bacillary dysentery, cholera, amoebiasis, or giardiasis. When diarrhea is associated with systemic infection, especially in malnourished patients, prematurely born patients, antibiotic has to be given. Usually, anti-motility drugs or anti-binding agents are not recommended. Even the anti-secretory agents also not recommended in acute diarrhea. Management of acute dysentery in children. So we know that dysentery is nothing but blood, stool mixed with blood. It may be bacillary dysentery or it may be amoebic dysentery. So for bacillary dysentery, if patient is very sick, go with the IV antibiotic, that is ceftriaxone 50 to 100 mg per kg per day for 3 to 5 days. If patient is stable, you can give oral ciprofloxacin or oral cefixime. Give for 3 days. If patient is check for improvement. If patient is improving, okay. If patient is not improving, give some other alternative antibiotic. Azithromycin can be given in shigellosis. For amoebic dysentery, metronidazole or tinidazole is the drug of choice. If patient is having a persistent abdominal pain and blood in the stools, you can suspect intussusception and evaluate accordingly. So what are the principles of managing persistent diarrhea? That is, persistent diarrhea is nothing but diarrhea lasting for 14 days, lasting more than 14 days. Then what you should, as other diarrhea, first you have to correct the dehydration, electrolyte imbalance, hypoglycemia. Then you have to evaluate by proper investigations like hemogram, blood culture, urine culture, and you have to treat accordingly. Apart from all these two things, you should check the nutritional status and give a proper nutritional therapy. So we have special notes on cryptosporidiosis. It is the cryptosporidiosis most commonly present with acute, subacute, or watery diarrhea. Usually, it has nausea, vomiting, lower abdominal pain, non-specific symptoms. These cryptosporidian patients range from asymptomatic to severe diarrhea. In immunosuppressive patients, it may present with more severe disease. So one third of the patients may have fever and malabsorption is very common. The special thing about cryptosporidiosis is it may invade the biliary tract and causes sclerosing cholangitis, and it may involve the pancreatic duct and cause pancreatitis. So especially among the patients with severe disease and low CD4 count, you should also check for these things. So diagnosis is usually done by microscopic visualization of the oocysts in the stool. The stain usually we use is acid pass stain. We have other methods like concentration methods, and we have ELISA and immunochromatographic tests also can be used to diagnose the case. In some cases, you may need a biopsy, intestinal biopsy. If patient is having a profuse diarrhea, a single stool sample is enough. If patient is having a mild disease, you may need a repeated sample testing to diagnose or to confirm the cryptosporidiosis infection. Prevention and treatment. For prevention, as we know, the patient is more severe the immunosuppression, more severe is to get these infections. So initiation of ART and proper ART initiation is only method to prevent the infection from cryptosporidiosis. The treatment is first, as we know, with all other diarrhea diseases, we have to correct the dehydration, and rapid ART has to be given. And antibiotic you should use is netazoxanide 500 mg to 1000 mg twice daily for 14 days, or paramomycin 500 mg 4 times daily for 21 days. Note on cystoisosporiosis. It is also most common. It most commonly presents with watery diarrhea, non-bloody diarrhea, abdominal pain, and may have a low-grade fever. Patient may have profuse and prolonged diarrhea, and watery diarrhea causing severe electrolyte imbalance and malabsorption. May lead to hypokalemia and malabsorption. Usually, we diagnose the case by microscopic evidence of oocysts in the fecal sample. Modified acid fast techniques has to be used to diagnose it. Sometimes you may need a intestinal aspirants or mucus from the biopsy specimen to detect the oocyst. Prophylaxis, CPT prophylaxis is recommended in case of isosporiasis. Treatment is Ceftriaxone. If patient is allergic to the sulfa drugs, then you can give pyrimethamine or ciprofloxacin. In case of children, 5 mg per kg per dose of trimethoprim has to be given. If it's not improving, you can increase the dose and duration 3 to 4 times daily for 10 days. For chronic maintenance therapy, Ceftriaxone has to be given 3 times weekly. Other causes of diarrhea in CLHIV. So apart from all those infections, even the Mycobacterium tuberculosis or Mycobacterium avium complex also causes chronic diarrhea. So as we know, mycobacterial tuberculosis usually affect the small intestine, especially ileum is most commonly affected. It can also affect large intestine. So patient may have abdominal pain, distension, and rectal bleeding. On examination, you can find hepatosplenomegaly, abdominal tenderness. On ultrasound, there may be multiple lymphadenopathies and splenic microabscesses can be seen. So there are evidences of disseminated TB. If mycobacterium tuberculosis is the cause of diarrhea, you can see other TB sites. From there, you can diagnose the TB. So one more virus which causes diarrhea is cytomegaloviral infection, as we have learned earlier. It can affect both the small and large bowels, especially cecum is most commonly get involved. So if cecum is get involved, it causes perforation and acute. They may present with acute abdomen, life-threatening complications. So a patient with CD4 count less than 50, and the patient is also having CMV retinopathy or eye symptoms, and you evaluate for CMV retinopathy, you found to have CMV retinopathy, then you can diagnose this case as a CMV causing diarrhea. So treatment is ganciclovir or valganciclovir. Ganciclovir 5 mg per kg IV BD or valganciclovir 900 mg orally BD can be given in case of CMV ulcers. So other non-infectious causes of diarrhea, as we know, after non-infectious causes, drugs are the most common cause of diarrhea. In CLHIV, lopinavir, ritonavir is associated with diarrhea. So after ruling out all other causes, you can think of this drug-induced diarrhea. And if you think that this is the cause of diarrhea, then you can stop those drugs and you can switch atazanavir in place of lopinavir. And you can give loperamide, that is anti-motility drug, in case of drug-induced diarrhea. And if patient is on TB and you are planning to start atazanavir, better you shift rifabutin rather than rifampicin. Oesophageal is also one of the cause for chronic diarrhea. It affects even small and large bowels. Most of the times it will be undiagnosed. In the 80% of the CLHIV with Kaposi sarcoma have a GI system involvement. Treatment is we have to send the patient for chemotherapy and ART has to be given. Effective ART has to be given. So, and other GI manifestation you can see is anal lesions. There are both infective and non-infective lesions are there. Perianal hematoma. Usually it is seen as a painful lump. They complain of piles during, especially constipated patients, during passage of the stools, they feel pain. There will be a painful purplish lump on examination it will be visible under the skin. It occurs due to the rupture of underlying vessel. So usually painful due to the stretching of the skin. Treatment is it will get absorbed by itself. No need of special treatment, but you can give a local painkillers or local anesthetic gels to decrease the pain, and you have to soften the stools. That is, constipation has to be treated. Thrombosed piles, it is an acute surgical emergency where patient will have a very much painful swollen lump in the anus and it will present with bleeding. You can see a red tender lump in the anus. It won't be there on outside of the skin. So perianal abscess, like any other abscess, it is present as a tender hard swelling. Incision drainage has to be done for this. So perianal fistula, usually patient present with painless post-snelling discharge. So on looking at anus, you can see the opening of the fistula with discharge from it. Treatment, if there are chronic discharging sinuses are there, you can think of TB and evaluate and give a TB treatment. So other animal lesions we have is herpes simplex. As we know, herpes simplex present with clusters of vesicles or shallow ulcers. Treatment is acyclovir 400 mg thrice daily for 5 to 7 days. So other skin lesions at the anus is human papillomavirus lesions. As we know, they present with warts or condyloma accuminata. They have a typical cauliflower appearance. How to treat local preparations like podophyllin. They may present as anal ulcer also. It is a pre-malignant condition, so better we have to refer the patient for further management. Proctitis is presents with anal discharge or pain or itching. It may be mild to severe. And syphilis usually presents with the primary chancre, as we have learned earlier that it causes a painless ulcer with raised edges. It looks like a wart, but the raising is more with the HPV than the syphilis. Thank you.
Thank you so much, ma'am. Any questions from participants? Please feel free to unmute your mic. You can also type your questions in the chat box. The next session will be held on 25th of April, and the topic is HIV and co-infections, hepatitis and leishmaniasis. Any questions regarding this topic, HIV and OI, gastrointestinal system? Please feel free to unmute your mic. Ma'am, I don't think there are any questions. Can we quickly run the feedback poll? The feedback poll is now visible on your screen. All the participants are requested to please answer all the 4 questions. Requesting all the participants to please complete the feedback poll on the screen. Once again, thank you, Archana ma'am, for taking out time for conducting this session. Thank you to all the participants for patient listening. We'll conclude the session.
Thank you.
Thank you.